everyone. Let's make sure this is right. Okay, perfect. Hi, everyone. Welcome back to a CCRN webinar. My name is Rebecca Coulter. I am the CCRN instructor for Archer Review, and we are so excited today because this is our first webinar post-launch. So I hope that some of you found this webinar by receiving an email about us launching this product, and you've already been able to check out the site. But if not, I'm going to show you just a little bit of a preview of it in case you're interested in looking at the CCRN product that we just launched on Tuesday. And then we're going to dive into some practice questions and just some good CCRN concepts in the cardiovascular system, which is my favorite, which is why I wanted to kick off with that today. So like I said, my name's Rebecca. We are just going to first take a look at the site and show you how you can access the CCRN product. Just going to spend a couple minutes there, then we'll dive back into some questions. And this will be a little bit more interactive than our webinars in the past, where I've just been doing a lot of lecturing, a lot of talking. This, I am going to be obviously going through practice questions, and I would love to see what your thoughts are about the questions, what your thought processes are as you're working through questions, and we can just kind of work through some strategies there as well. So first of all, I'm going to pop out of this presentation and show you our Archer site. See if this is showing up right. I think so. So this is just Archer Review. If you just plug in archerreview.com, this is what comes up. If you come over here to our nursing tab, that's where you can find our CCRN product. And right now, really exciting news, it is for free. You can use the entire product for free for 30 days from your activation. So when you come here, you have a try for free button right here, which will take you down to where you can add it to your cart and go through the purchase of it. But again, it's free, so it's pretty easy. You don't have to put in any payment information. And what you're getting when you get this CCRN product is our Q Bank, which is 1,000 questions, over 1,000 questions, and all of our on-demand content. So I kind of want to show you a little bit of what that is going to look like when you do go ahead and, like I said, quote unquote, purchase this. This is what our on-demand videos look like. We've got all these different topics that you can watch. You can see how they're bite-sized pieces going through all the different modules, covering every single concept that you can expect to see on the CCRN exam. And then we also, like I said, we have the Q Bank, and this is broken down into subjects and lessons, and you can get all this different data once you start to take these practice questions. We have 1,085 total questions for you, and they line up really well with the CCRN test plan, where it gave us percentages, like 14% of the exam is cardiovascular or respiratory. Only 4% is neurological. So that's all taken into consideration with that Q Bank. I see a question here. What is CCRN? That's a great question. Let's talk about that first. We've done a few of these webinars. We've been doing these webinars since, I think, October, kind of as we lead up to this launch of this event, launch of this product. So I've given my little spiel on the CCRN a million times, but didn't include it in this one. So let's talk about it a little bit. CCRN stands for Critical Care Registered Nurse. So it's a certification that you can obtain after getting experience as a critical care nurse, usually for about a year full time, a little bit longer if you're going to work part time. And then you're able to sit for the exam. And that's where your knowledge is tested a little bit to see if you have proficient knowledge in critical care concepts. It's considered a pretty difficult exam, which is why Archer Review wanted to come together and create a product for it and help nurses feel prepared for this test. And so we've got 13 plus hours of on-demand video content, which is what I was just showing here, and then that 1,000 question Q Bank. The test is about 125 questions split up over the whole slew of different concepts that you can see in critical care. And then once you're certified, you have some letters to add to the back of your name. I know for me, it increased my confidence as a bedside ICU nurse quite a bit. So it's great if you're looking to go back to school for your resume. It's usually your hospital will provide some sort of financial incentive to become certified. So there's a million reasons out there to become certified. really help boost your career at the bedside. So we are very passionate about CCRN here and super excited to have launched this product. Hannah, I see that you said you started watching the on-demand videos today and you love it. Thank you so much. I'm so glad that it's going well. We are so excited to hear feedback since we did just launch this and we're, letting it be out in the world for free right now, kind of hoping people will really use it, try it out, and let us know what they think. We want it to be a helpful product for you. So thank you so much for that feedback, Hannah. I really appreciate it. Okay, that is it for kind of just how to navigate the site and get you to this CCRN product. Let's go ahead and dive into some questions. Let me just change my screen here a little bit. Okay, pop back over here. And now it'll become a little bit more interactive, which is exciting. So let's start here with question one. Like I said, these are all going to be have a cardiac focus. I wanted to kick things off with my favorite system, so I'm a little biased to it. And we're going to start here with a balloon pump question. The CCRN is not a cardiac surgery or cardiac medical exam. There are other certifications for that. So the CCRN is not going to care that you know extensive details about every single cardiac assist device out there, but they do care about the balloon pump because the balloon pump is a device that we can see in such a large variety of ICUs. It's really not only specific to cardiac ICUs. So this is the device of those cardiac devices that if you're going to focus on one, this is the one to focus on for the exam. So let's go ahead and get started here. This question states, a patient with cardiogenic shock is being managed with an intra-aortic balloon pump or an IABP. The nurse notes decreased urine output and cool modeled lower extremities. What is the nurse's priority intervention? And I will just read aloud these answer choices here. A, increase the IABP augmentation. B, assess the IABP placement and timing. C, administer a bolus of IV fluids. Or D, begin a vasopressor infusion. I'm seeing some answers come in. Good job, everyone. Seeing a couple different answers, which is great. That means we've got things to talk about. I love when we have different answers. I'll give this just a couple more seconds. Yeah, a couple different answers. Okay, I'm going to go ahead and say it is B. B is our correct answer. Now, I saw some people say C, which I don't blame you for at all. And that's why we're going to spend some time talking about the right answer. So B is correct. What we saw in this question, I'm going to come back here to the question. We see this decreased urine output and cool modeled lower extremities with a patient that's in cardiogenic shock. Now, what's interesting about cardiogenic shock is it can cause these symptoms. We can see poor perfusion, hypoperfusion, lead to somebody having decreased urine output and cool modeled lower extremities. And that could mean we need to support this patient more. So that could be in the form of a bolus of IV fluids. That could be in the form of beginning a vasopressor infusion. All of that makes sense. Even increasing the IABP augmentation to make the balloon pump work a little bit more for this patient. However, these symptoms also align with when our balloon pump is not in the right position. So this is where our balloon pump sits in the aorta. And we want it to be below the three branches that come off the aorta. So this left subclavian artery, we want it to sit below that. And we want it to sit high enough in the aorta that it's not obstructing our renal arteries or a femoral artery. So when we first see these symptoms, let's say you've got a Foley catheter in your patient and you first see the symptom of, oh, wow, last hour we had 60 milliliters of urine output and this hour we only have 10. I am thinking first and foremost, is my balloon pump in the right position? Did it get withdrawn out of the patient a little bit, a few centimeters, that now it's occluding my renal arteries that hang off the descending aorta. And especially if I'm seeing those perfusion changes in my lower extremities, that is also an indicator that we might have a malpositioned balloon pump. And that's the first thing we're going to check. Now, once we rule that out and we say, okay, it looks like our balloon pump's in the right place and our timing, the balloon pump's working at the right time, that's when we're going to go to, okay, we kind of need this patient to get some more support because we're not perfusing our kidneys well, we're not perfusing our lower extremities. So that's when we'll start thinking about increasing augmentation, doing a fluid bolus, or adding in a pressor to increase perfusion. But first of all, we always have to check positioning, especially when we see that urine output decrease. If we lost a left upper extremity, a left radial pulse that we check every hour, if we lost that, we would be concerned that the balloon pump had been malpositioned as well, but instead of being pulled down towards the descending aorta, it got pushed in and it's occluding that left subclavian artery. So we're always checking positioning. Okay, that's not the easiest question in the world. I really appreciate everyone participating. Let's go ahead and talk about our second one. So with these questions, if you haven't noticed, I'm going to try to give you a little bit of content that we'll discuss with the question to kind of close the loop on the information. So question 2, a 66-year-old patient with Marfan syndrome is admitted to the ICU with sudden onset severe back pain. We should have red flags rising when we hear that. A CT scan reveals an acute type B aortic dissection involving the descending thoracic aorta with without signs of rupture or malperfusion. What is the first line treatment for this patient? A, serial imaging and observation. B, immediate open surgical repair. C, endovascular stent placement. And D, begin medical therapy with beta blockers and vasodilators. What do we think about this one? There's a few details in this question that kind of give us the insight that we need. Seeing a few answers come in, they're all looking good. Give this just a couple more seconds here. Yep, couple different answers. Love to see it. That means we've got lots to discuss. Never a bad thing. That's why we're doing this. Okay, great. Yeah, I see actually a lot of different answers. I think every single answer is covered here. So yes, this is why we have a product for CCRN, and we know it's a difficult exam, and these practice questions are definitely in that category. So I think we got majority of the right answers, which is D. Our first line treatment for this patient, let me pull my thing up here with a cursor. Oops. Our first line treatment when we have a type B aortic dissection. So we know that there's a flap that's occurred now, but we're not seeing signs of rupture with that dissection rupturing or malperfusion, meaning this is a stable dissection. Our first line treatment is going to be D, medical therapy with beta blockers and vasodilators. We're hoping to get heart rate down, blood pressure down. Some beta blockers we can use is labetalol or esmolol. We can use vasodilators like nitroprusside. We will also do serial imaging for this patient, but it's not necessarily a treatment. One thing I like to think of when I think of imaging is it's not an intervention within itself. It can lead to an intervention when we see things on that imaging, but it's not going to treat that patient in the moment. That CT scan isn't giving them any sort of therapy. It's just giving us more information. So we want to do ongoing monitoring, but our first line treatment is going to be this pharmacology therapy. Now, our other two options was surgical intervention to fix the dissection or placing an endovascular stent to help bolster that, that aorta. And those are options as well. But when we are not seeing any sign of rupture or any sign of um, reduced perfusion for the patient, we're not at that point yet. We'll actually watch that dissection for a little bit longer, or get it on the schedule to have them maybe get an intervention later on. But the first thing we're going to do is lower their blood pressure to not put further stress on that active dissection. Marfan syndrome, great question, is a genetic disorder that really plays a role with patients' different heart valves and their vascular system in general. When I would have patients with Marfan syndrome, when I worked in the cardiac surgery ICU, they are typically really tall. It's a lot of times it's males that have Marfan syndrome, not 100% of the time, but more males than females. Very tall, long extremities, and for some reason, their cardiovascular system is just a little abnormal in the sense of their cartilage is different. So I remember having Marfan syndrome patients that needed, by the time they were 40, they might have already had 4 different valve replacements in their heart, 4 different open heart surgeries, even though they're perfectly healthy otherwise, took care of themselves, no other risk factors. But the Marfan syndrome causes those structural defects, and it can affect the vascular system as well with the aorta. So they're just more at risk for things like an aortic dissection or an aneurysm. Great question. Okay, great job, everyone. And the cause for Marfan syndrome is purely genetic. You're born with it. I really don't think it's something that can be acquired later on, but I could be wrong about that. All right, let's move on. Or actually, I've got a slide here that talks about this. We can see that type B is when we have that descending aortic dissection. Abe Lincoln did have Marfan's, great point. That's how I remember it too. If you remember, how tall Abe Lincoln was. And he clearly, had a great quality of life. It's not something that, is going to make you bedridden for the rest of your life or anything like that. But your heart and vascular system just does typically see some complications. And with this, I've got the treatment. So our first treatment here is going to be reducing that blood pressure before we think about any surgical intervention. Great job, everyone. Okay, question 3. During a routine assessment, a nurse notes prominent jugular vein distension, or JVD, in a patient who reports progressive shortness of breath and lower extremity swelling. Which of the following conditions is most likely responsible for this finding? A, we have dehydration. B, we have sinus bradycardia. C, cardiac tamponade. Or D, hypovolemia. Great job. Great job. Seeing some answers come through. Good job. Great job. Okay. I think we're all on the same page here. That's exciting to see too. Everyone's doing awesome. So yes, this is cardiac tamponade. Answer is C. So what triggered that we thought this was cardiac tamponade? Well, first we can knock out answer choices a lot easier with this one. We know when we've got jugular venous distension, we're probably not dehydrated. Sinus bradycardia, I've never would lead to a cardiac output problem potentially, but is not typically associated with our jugular venous distension. And hypovolemia, again, not going to be a symptom for JVD. Cardiac tamponade, we can see that we would lead to JVD because we are not able to let blood exit the heart nearly as effectively. So we're going to have that backup of blood flow, and that's going to increase our JVD. We're having that backup of blood flow also in the lungs because the left side of the heart's not clearing blood either. So it's total heart involvement when we have cardiac tamponade. So the right side's going to lead to the backup of the blood flow to the venous system with our JVD and lower extremity swelling. And the left side of the heart is going to lead to that shortness of breath as we have a backup of blood flow into the pulmonary system. So yes, great job, everyone. Make sure I didn't miss any questions. Perfect. Okay. And for this one, I have a little slide on cardiac tamponade, but we seem to really understand that one pretty well, which is great. I didn't even mention this Beck's triad for cardiac tamponade includes JVD, jugular venous distension, muffled heart sounds, and hypotension and narrow pulse pressure. Narrow pulse pressure, because with cardiac tamponade, we're restricting both phases of our cardiac cycle, both the systole and the ability for the heart to fill in diastole. So we'll see that lower systolic pressure, and the body's going to try to compensate for that by vasoconstricting the rest of the peripheral extremities. That's going to increase our diastolic pressure. Great job, everyone. Let's move on to the next one. Okay, a patient with a temporary pacemaker is experiencing frequent pacemaker spikes on the ECG that are not followed by a corresponding cardiac response. The pacemaker is set to synchronous or a demand mode. What is the best initial intervention? A, increase the pacemaker's milliamp or MA output. B, switch the pacemaker to asynchronous or a fixed rate mode. C, assess the patient's intrinsic cardiac rhythm. Or D, notify the healthcare provider immediately. Good job. Couple different answers here. Yeah, I'm seeing a few different answers. This is a tough question. I kind of picked tough ones for today. I'm not going to lie. They are not easy. And I see where everyone is coming from, seeing answers all over the board. So this is another device, temporary pacemakers, that might be a little bit more specific to our cardiac ICUs, but again, we can see them everywhere. So the test plan is going to ask about them. Our answer, which I don't think I saw the most of, which is, again, always a good thing in a way, because that means we've got lots to talk about. Our answer is A. So what we're seeing here, notice how the question, let me go back to the question, focused on how the ECG is having pacer spikes, but we're not seeing a corresponding QRS complex following that pacer spike. Now, as a nurse, we are able to troubleshoot this ourselves. If we continue to run into problems, that's when we need to notify the healthcare provider. But there are some things that we can do under our scope of practice before having to get the healthcare provider involved. This is not necessarily an emergency. What we want to do is increase our pacemaker output. We're seeing the pacemaker spikes, but we're not getting capture. And I'll show you what that looks like. This would be, sorry, there's a weird shadow on this image. I think when I moved it over to this presentation, that must have been added on. But you can see here how we've got pacer spikes before our P wave, and then a pacer spike before our QRS. And we've got a QRS following that pacer spike, but it's not a paced QRS. That is the patient's intrinsic QRS because it looks normal. If the pacer was causing that QRS complex, it would look like this. We see a really wide, funky looking QRS to prove to us that it was the pacer that did that. So what we need to do is increase our milliamps because the timing is right. We're seeing it's in the right time. It's picking up on the patient's intrinsic rhythm enough. But it's just not fully capturing and getting that ventricle to contract when we want it to. So that's what we're looking for, is this change. So because of that, we can just increase our milliamps, give that wire a little bit more juice so that it can grab that ventricle muscle and actually cause it to contract. Now, we don't want to switch over to an asynchronous mode for B. Asynchronous is kind of a dangerous mode. It's going to pace that heart no matter what the intrinsic rhythm is. And that can lead to something called R on T, where we're causing a QRS complex on a T wave, and that can send somebody into VTAC. So asynchronous is a mode that we still use it, especially to override somebody's intrinsic rate more effectively, but it's one that's a little bit dangerous. Now, C, assess the patient's intrinsic cardiac rhythm, is not a bad idea. You could still do this, but it's not going to fix our problem. Our problem is that the pacer is not capturing, it's not causing a ventricular contraction or a QRS complex. So the problem is we don't have enough juice in our wire. But this, I pretty much anytime I have any problem with a pacemaker, I don't think it's a bad idea to check the patient's intrinsic rhythm just to get a good idea of that, but it's not going to be really our intervention. So that's what makes this question a little bit difficult, because I think anytime I ever have anything going on with my pacer, I'm checking my intrinsic rhythm, but it's not the intervention. The intervention is going to be increasing my milliamps. And then notifying the healthcare provider, we can also do that. We can notify our healthcare provider that this happened, but I would want to call them after I've gotten some more information. I might call them and say, hey, I had to increase the milliamps up to 20 or 15, whatever it was. So that they know that, but I would have hopefully kind of fixed that problem before letting them know. Or, I'm trying to increase my milliamps and I'm still not getting capture, because that's going to be the first thing they tell me to do on the phone. If I'm noticing pacer spikes, but I'm not seeing a QRS complex, they're going to be like, well, did you give the wire more juice? Did you try to do that first? And I would want to have that information for them. Um, okay. At what situation do we assess this situation? So this would be like if your patient's on a continuous cardiac monitor and you just see, oh, we've got pacer spikes, but I'm not seeing a QRS following that pacer spike, meaning the pacer's not really working. That's when you would notice this. We also assess our pacer thresholds and everything, usually at least once a shift at some facilities. Other places it's every 4 hours. That's kind of facility dependent. So yes, our answer for this one is going to be A. We want more juice to cause capture. Okay, we are just about out of time. I'm going to do one more quick question. This one is kind of a doozy, I'm not going to lie. But I will just see if we can get through it here. This is a great question, and kind of encompasses a lot of different concepts. So, patient is admitted with hypotension and jugular venous distension following an inferior wall ST elevation myocardial infarction, so an NSTEMI, or I'm sorry, a STEMI. The nurse is assessing the patient's hemodynamic status to determine the most appropriate initial treatment. Which of the following findings would indicate the need for cautious fluid administration? So what's that saying is that we need to kind of be really careful when we give fluid. That's kind of what that wording is meaning. Now, this is going to be talking about pulmonary artery pressure numbers. So when we have a pulmonary artery catheter in place, that's what we're looking at here. So PAP stands for pulmonary artery pressure. PAOP is our pulmonary artery occlusion pressure, or our wedge pressure. And CVP is our central venous pressure over on the before we even get into the heart. And then we've got ST elevation leads and a lung sound symptom. So this is why this is kind of a hard question, because we have to be paying attention to so many different details. I'm not going to read these aloud. I'm just going to have you guys read through them, just because I think it'd be more confusing if I read them. Excuse me. Seeing a few different answers. I think I've maybe seen one correct answer. This is a tough question. Okay, let's go ahead and start talking through it. So, first of all, let's take a look at what our symptoms are here. We have hypotension and jugular venous distension. So we know following a myocardial infarction, so our heart's not doing well. We have hypotension. JVD is a really good one. That kind of tells me maybe where this STEMI could have occurred. That my right side of the heart is dysfunctioning because I'm having that backup of blood flow in the venous system. And we're told that it's an inferior wall STEMI. Inferior wall will always mean right side of the heart. So what we're looking at here is right ventricular failure, which is going to lead to that backup of blood flow, leading to JVD, can also lead to hypotension because we're not able to supply the left side of the heart as well if our right side is struggling. We've got this pulmonary artery catheter in place. We're suspecting this right ventricular failure. What we're going to see is a normal pulmonary artery pressure. So I'll go ahead and tell you our answer is B. Normal pulmonary artery pressure because the pulmonary artery is after the right side of the heart. So if we had a left side of the heart problem, we'd see that backup of blood flow going into our pulmonary system. That would lead to elevated pulmonary artery pressure, but we don't have that. We have a poor functioning right side. So the pulmonary artery pressure is actually going to be normal. Same with our pulmonary artery occlusion pressure because our left ventricle is still doing an okay job emptying out the left side of the heart. So we're not going to have an elevated filling pressure on that left side. That's what that wedge pressure, that PAOP really gives us an idea of, is how congested is that left side getting. Elevated CVP because we've got that backup of blood flow from the right side of the heart leading to the venous system. ST elevation in 2, 3, and AVF. Those are just the leads on the ECG that correlate with an inferior wall MI, STEMI. And clear lung sounds, again, this is a right-sided problem. This is not, the left side having a backup of flow into the pulmonary system. So we'll have clear lung sounds. So this question takes knowing a lot of different pieces of information. You have to feel confident. I'll stop here for a second, just so when people are watching the replay, they can pause it if they want to read those rationales. I kind of just talked through them. When we look at our ECG interpretation, this is just a memorized thing, unfortunately. This isn't one of those ones that kind of makes sense and then you don't have to memorize it. You kind of have to memorize it. And just knowing that inferior leads are 2, 3, AVF, indicating a right coronary artery occlusion. It's inferior because of the way the heart is positioned in the thoracic cavity. It's kind of on a tilt. And so the right side of the heart is actually kind of facing our posterior side, inferior. That's why when you get an echocardiogram and they do either a transthoracic or a transesophageal, the transesophageal is so much better at visualizing our right side, all the structures in the right side and how the right side of the heart is doing. The thoracic usually can't really the right side of because of the way the heart is tilted in the chest. So inferior, I'm just telling you all that to help you remember that inferior is talking about the right side and this right coronary artery. So yes, that's 2, 3, and AVF. We have to remember our blood flow through the heart for this, to remember that when we've got right side of the heart dysfunction, we're going to see that backup of blood flow in our CVP, superior vena cava, inferior vena cava, jugular venous distension, etc. If it was a left side problem, that's when we'd be worried about lung congestion. And then we finally need to have some knowledge about our pulmonary artery catheter and what those pressures are going to look like. So this is what that pulmonary artery catheter looks like, how it sits in the heart and the pulmonary artery. And then these are all the pressures. I've got 2 slides for this. These are all the pressures that it tells us. Central venous pressure, pulmonary artery occlusion pressure, pulmonary artery pressure. I mean, it goes on and on and on. I've got 2 slides for it. But we can use this pressure interpretation to tell us, okay, if we've got an elevated CVP, that means our right side of the heart is dysfunction. We've got a preload, lots of preload at that right side. So that is it's a difficult question. It takes putting a lot of things together. So great job, everybody. I'm running a little bit over on time. This is just a little rapid 30, go through some practice questions together. Thank you so much for all the participation. It was fun to go through it together. Does anybody have any questions about any of those concepts that we talked about today? I know we bounced around to a lot of different things. You're welcome, Hannah. Thank you for being here. I'm going to just pull up this again. Because we are live. I know we've been kind of teasing this product for a really, really long time. So it's really exciting to have it out. How long will the free trial be available? That's a really good question. We um we actually don't have that totally nailed down yet. We just know it's for a limited time. So I would definitely try to snag it if you are for sure that you want to use it and give it a shot. Um, I have not heard exactly when we are going to start offering it for a cost. We do know what pricing is going to look like. So right now, we're offering it for free for 30 days. And then once, if you decide you want it one for longer than that, or two, once we start charging, it'll be 160 for a year of access to this. So that if you wanted to take a good amount of time studying these concepts, then you'd have that a whole year. Will you guys continue to add questions to the Q bank? That I'm not too sure about. I think we'll for sure be watching like the feedback that we get from questions and adjusting questions. Potentially over time, we might start swapping questions out. The Q bank as it stands is pretty robust. So I think it should be completely sufficient for somebody if they're sitting down for a 2 to 6 week period to study for their CCRN. Going through 1,000 practice questions like this should be sufficient. So I think it'll probably stay pretty much the same amount, but that could change. Thank you so much. Little compliments here. I appreciate that. Is the setup similar to the CCRN, just like it was the NCLEX with practice questions? Yes, great question. It has all those same metrics built in, so that you can choose, you can go in and build your, if you want to just look at cardiovascular questions, you can do that. Same kind of setup here with creating a test being mostly in tutorial mode so that you can get instant rationales. If you're in a timed mode, that's when it'll kind of mimic the exam environment. You won't get instant rationales, but you'll get them at the end. But it just kind of keeps the integrity of the testing going. And you can make sure you're only using unused. You can choose your test length. You can choose from which module you really want to focus on that day, if it's respiratory, neurological, etc. You can really cater this to be very, very helpful for you. And then always look back at answers that you've already taken a look at. And all those rationales. And then here's our on-demand content. Again, just broken down into usually 8 to 15-minute sections, so that you can get really good bite-sized information. And only if you really want to focus on one system or one concept that day, you're able to do that really easily. It's very personal. I was about to say personalizable, but I don't think that's a word. You can personalize it very easily. Let's go with that. Okay. Oh, thank you so much. Everyone is very kind. I'm so glad that these webinars and everything have been so helpful. That is really encouraging to hear. I like to think that our on-demand content is just it's even more polished, and a little bit more information on some of these videos. So if you liked the webinars, I think you'll really like our on-demand videos as well. Okay, I think I'm going to go ahead and close out here. I'm a little bit over on time anyway. Thank you guys for sticking around, and definitely reach out to us if you have any questions at all, or if you try the product and you've got any feedback for us. We would love to hear it. So we will see you in a future webinar. We're going to continue to do it. Going to continue to do these on some sort of schedule that I haven't quite decided yet. Pretty consistently though, because they're just so fun. Lots of going through questions like this, and we can just talk through concepts together. Okay, everyone, have a great rest of your Thursday. We'll see you.